So again, tying into those systems is critical. So what do you get when you go through this whole process? What are the benefits of becoming a team if we look at these particular high-performing attributes? What I've seen is that all staff feel like they're involved in care. I quite often have gone into offices that have done this work, and even the receptionists who have no clinical background feel that they're involved in patient care, because maybe they're printing off a patient summary from the registry and making it available to the provider at the time of the visit. Maybe they're delivering self-management support assessments while the patient's waiting in the waiting room and helping them answer some questions. So they get engaged with the patient. Everyone on the team feels like they're involved in patient care and not just doing a bunch of tasks on a daily basis. When high-performing teams delegate tasks across all team members, what you see is that there's more efficient and safe care, and there's very good research that shows that teams with clear delegation of roles and tasks and responsibilities get work done more quickly, they get it done more safely, and the physician time during that visit is spent more on medical management rather than running around and trying to figure out whether a lab exists, where's the paper record, why is there a page missing in it, so on and so forth. So the whole team ends up benefiting from that team approach. It's clear again from the research that allied health professionals are more likely to carry out tasks and activities during the chronic care visit than if we leave it all up to the physician to do. The orientation south of the border, and I think to a certain extent in Canada, is the physician tries to do everything. In the States, the worry is that physicians worry that if they delegate work to their staff are going to make mistakes and they'll be sued. In actual fact, the research shows that if you take that orientation and try and do everything, you as a physician will make way more mistakes than any of your allied staff ever will. So it's what we're seeing with these teams that are functioning well, the task delegation is clear, everyone has their roles and responsibilities, they're working up to their scope of practice, and they're more satisfied with that. The other thing too is when you orient patients to team care, they're more willing to see non-physician people when they need to come in. So if someone's coming in and has something, a sprain or an injury or something, a mild exacerbation related to their chronic care, they're more willing to see a nurse practitioner. They're more willing to see the nurse. In many cases, they're more, if it's around self-management support, they're willing to talk to the medical assistant, whoever can help them with whatever they're doing, because they see you as a team. They don't see you as a physician and other people. The other thing we know is that staff churn rates drop dramatically in good team care. People don't get bored. They feel engaged, so they stick around longer. You don't lose front office people as much. You don't lose medical assistants as much. And clearly, what that translates into is job satisfaction increases for everyone. Does planned care really make a difference? What are the benefits of that? Again, what I hear from teams that do this is they feel their days are less chaotic. They don't feel like they're not coming into the office with apprehension of what is this day going to be like. The other thing I'm hearing too is that they actually go home earlier, which from what I understand is probably one of the biggest benefits of all of this work. Many practices, the components of the frame or in the version in the States are going home at 5 o'clock at night. So there's a huge benefit in terms of just getting your life back and not spending 12 hours a day in the clinic. The teams are better prepared for surprises. So when a patient shows up that they aren't expecting, that is in real dire straits, they're better prepared to manage that particular visit. They also tell us that they're happy because they're delivering all the primary and secondary preventive care that they know they're supposed to do, but critically, they're very satisfied because they're delivering the care that they were trained to do. When I talk with teams that go through the framework, they say, this is what we thought we signed up for to do in primary care. And so, close to the cane. Sorry, used all my time. Go figure. But they're satisfied because they're doing what they were trained to do. Patients feel like they're part of a team approach. I've mentioned that already. They feel appreciated and feel heard because the visits aren't rushed, the visits aren't chaotic. And they feel that they have access to their providers, that it's not restricted. So the visits, again, are more orderly and the expectations can be set. We know from the research literature around the model, around the framework, that it improves care process outcomes, it improves clinical outcomes, and utilization in primary care does not necessarily increase. So while you may be bringing patients in for more planned care, it reduces the number of acute visits that they have in the system, it reduces specialty visits, and it certainly reduces visits to the ER. The benefits of self-management support: patients are now engaged in their care. They're less passive. They're more confident. Once you build confidence in patients, they do a much better job of taking care of themselves. And over time, as you teach patients self-management support, it becomes self-supporting in itself. They learn to do it without you having to continually check in or set new goals and action plans. So while you'll always be checking on them to see how they're doing in terms of their self-care, it becomes a self-sustaining process and they manage themselves much better. It's linked to improved clinical outcomes. Many patients are willing to do this work through group supports and group visits, and anyone on the team can help patients do self-management support, and many people on the team like to do this work. So talk to your team members and see who would like to do this kind of behavior change work with patients. Information technology. Patient summaries that facilitate individual plan care were the biggest learning we had from teams. They would take their electronic medical records and their registries, and they would make sure that it printed a summary of what they did at the last visit with the patient. It highlighted what was done, what wasn't done, and that would structure the visit any more than an electronic screen or a paper-based record. So those summaries can be very powerful. I've talked about registry functionality and the ability to drill down into populations. It's absolutely critical. If you get patients involved in the IT piece, which is part of the eHealth work that will be coming over the next few years, patients will have portals into their records where they can manage their own self-management goals and action plans, they can check their own labs, they can make appointments, they can talk to you through email and determine whether they need to come in or not. So it becomes a much more fluid relationship. It's easier for you to take advantage of the incentives that are available from the ministry if you're electronicized, easier to collate data for external reporting and internal quality improvement, and clearly what we need to do is build IT that facilitates communications across different care settings. And then finally, does linking to the community really make a difference? It certainly does. Teams that are working well with their community partners have better streamlined referral processes. Those referral processes can be very cumbersome, but now they're very streamlined and there's clear communication around, this is what I'm doing with the patient, this is why I'm referring them to you, this is what I'm hoping you're going to do, and this is what I hope to hear back from you. Many patients can be funneled into community programs, so it relieves the burden on the primary care teams to do all of the self-management work. The use of community resources allows the team to focus on patients most in need of family practice intervention. Many patients just need some tweaking and some fine-tuning in terms of their self-care, which frees up you to take care of the more complex patients and the patients that need a full court press from you and your team. And then clearly community partnerships and getting patients into the community resources helps relieve a lot of the socioeconomic burdens that you see in practice every day. Patients may be willing to take care of themselves, but if they can't put food on the table, they're going to buy food before they buy medications. If they can't get past an abusive partner, but a community resource can help them with that, then they can focus more on their clinical treatment and treatment planning. So partnering with that community is absolutely critical. I mentioned this last night, and I'm not going to talk about it right now, but again, what you just want to do in terms of this change is get started with a piece of the framework. In the same way that you show patients a dinner plate of all the things that they need to do around their self-care, you let them choose one thing they want to start on. Take a look at the model, say to yourself, where do I want to start? Do I want to start with a planned visit? Do I want to start with setting a goal and action plan around self-management with a patient? Do I want to try and pull some data from my registry to see how I'm doing? Start somewhere and start small with your quality improvement. Test ideas very quickly and just start building towards this system. It will take a long time for you to change your practice. It's not going to happen overnight. But many, many teams, thousands of teams have done it across Canada and the US, and I'm sure you folks can too. Thanks very much.